Hello, everyone. My name is Priyanka Chablani. I'm a GU medical oncologist at UPMC in Pittsburgh. I'm thrilled to be here at GU ASCO today with GU Oncology Now to tell you a little bit more about the poster that we're presenting in bladder cancer today. So I will let my other co-authors introduce themselves. Go ahead.
Start with Karine.
Karine Tawagi. I'm a GU medical oncologist at UIC in Chicago.
I'm Khaki. I'm a GU medical oncologist at Stanford here in California.
Hello, everybody. I'm Dr. Petros Grivas. I'm a GU medical oncologist at Fred Hutch Cancer Center, University of Washington in Seattle.
So the rationale of our study is that the first-line treatment of patients with metastatic bladder cancer has really evolved with the FDA approval of EV-Pembro in the first-line setting after the results of the EV-302 trial showing a doubling in OS and PFS with EV-Pembro compared to platinum-based chemo. And this really became the default first-line preference for patients with metastatic bladder cancer. So we were in our survey-based study that we did, we were seeking to understand how GU oncologists in the country are treating patients in the second line after progression on EV-Pembro, what agents they're using, and how comfortable providers feel with IO re-challenge in the second line after progression on first-line EV-Pembro. So I'll let Ali tell us a little bit more about how we did this survey-based study.
Great, yeah. So we wanted to set out to have a survey, and before we assembled our survey, we developed a working group team of 11 sort of key opinion leader oncologists within the community, the bladder cancer community. We developed, with their assistance, we developed a number of questions that were vetted through a couple of different meetings. And then in May of 2024, we sent out the survey to a number of different GU oncologists around the US. And we kept the survey open through the month of August.
Yeah, and so we sent the survey out to 227 GU oncologists throughout the country and had about a 30% response rate. Greater than 70% of providers see over 25 patients with metastatic bladder cancer per year. So, really a group of providers that are seeing a lot of bladder cancer. And there was a range in like how long people were practicing for, from 0 to 5 years to greater than 20 years. So with this question of what providers are using after first-line EV-Pembro, we actually interestingly saw that about 80% of people did not feel comfortable giving IO with platinum-based chemo, so like gemcitabine or IO after progression on platinum-based chemo in the second line, or even IO on a clinical trial. So about 80% of providers did not feel comfortable giving that IO re-challenge. And also, it was another interesting finding is that 87% of providers felt very comfortable giving erdafitinib in the second line setting for patients with FGFR3 alterations. So, Karine, with the results of this study, how do you feel about not using IO re-challenge in the second line setting and the high interest in using erdafitinib for people with FGFR3 alterations, and how do the results of this study impact what you're going to do in your practice on Monday?
I think I agree with what the majority of respondents had for our survey study in terms of platinum-based chemotherapy in the second-line setting after EV-Pembro. We really have limited options outside of clinical trials, but I think there are some caveats in terms of how many patients are still eligible for platinum-based chemotherapy. I am sending next-generation sequencing at the onset of a new diagnosis of metastatic bladder cancer so that we can check for things like FGFR. Mm-hmm. And although I'm seeing it in a less proportion of patients than what's reported perhaps in other studies in my practice, but I do think that this is a space where we really need trials now that our standard of care has changed. Looking at the NCCN guidelines, we don't really have much guidance on what to do in the second line setting.
Yeah, no, great. And Petros, how about you with regard to this finding that the majority of providers did not feel comfortable giving IO combination with on clinical trials in the second line setting? What are your thoughts about that, and how are we investigating this as a field?
Thanks, Priyanka. I agree with the points that you already made. This actually concept and discussion illustrates the need to generate prospective trial data to answer the checkpoint inhibitor challenge question in metastatic urothelial carcinoma, because we do not have such data prospectively as we have, for example, metastatic RCC with CONTACT-03 and TiNivo-2 trials. What data do we have in this particular setting? We have a few retrospective studies. Ali, me, and other colleagues published a manuscript about a year or two ago in a small number of patients, maybe 25 patients or so, looking at this question, Priyanka, the checkpoint inhibitor challenge question. Mm-hmm. And we saw only 13% of patients had response to the second checkpoint inhibitor. Mm-hmm. And some of those patients had stopped the checkpoint inhibitor in the previous time because of toxicity or another reason. So we do not have prospective data. And I think in that context, I agree with you, I agree with the respondents in that survey that I'm not using checkpoint inhibitor monotherapy in clinical practice in patients who had already progression of prior checkpoint inhibitor until we get prospective data. And actually, we're designing a phase 3 clinical trial with the ECOG-ACRIN group and CTN, the ECOG-ACRIN 8231. Dr. Monica Joshi and Penn State is the chair, and I'm the co-chair. And the design is sacituzumab plus pembrolizumab combination based on the cohort 3 of the TROPHY-U01 trial that actually met the primary endpoint of the phase 2 trial, compared to platinum-based chemotherapy or taxane, tried to generate this data in patients who had already progression after prior therapy with checkpoint inhibition. So it's checkpoint inhibitor re-challenge question. Similar to contact 213 EVO2 to generate prospective data.
So definitely a lot to come with regard to this question of IO re-challenge. I'm looking forward to the results of seeing those trials. Karine, what do you think are some other shortcomings of our study?
So I think some of the limitations of our study are that it was primarily academic oncologists, and majority of patients with bladder cancer in the United States are being treated out in the community. So these are providers that are not seeing the same rate of bladder cancer patients per year as our respondents had. And I think the issue of neuropathy from EV and the ability to give platinum-based chemotherapy in the second-line setting is also an issue. So although that is what we would all say we would like to do, in reality, that might be a shortcoming as well.
Yeah, totally agree. So Ali, there were some other, I think, shortcomings of this study. What do you think is another question we didn't address?
I think that there are some other questions that still remain within our field, especially around the use of the sequencing or IOB challenge questions, and specifically around the use of immunotherapy in earlier settings. So for non-muscle invasive bladder cancer or for muscle invasive bladder cancer, either as adjuvant therapy like checkmate 274, or maybe even perioperative therapy like we've seen with the Niagara study. And so in hopefully future work from our same survey, we'll be presenting results of the same respondents and what their thoughts are about IO re-challenge and other therapies for these other populations.
And to your point, it was a fantastic discussion. We now have an evolving field. And as we discussed before, we have here two.
Yes, absolutely.
With immunohistochemistry, with using the gastric cancer scoring system to evaluate for potential trastuzumab deruxtecan as an option. But Ali, as you pointed out, we do not have good data about the optimal sequencing of therapies. And we need studies, retrospective, real-world, and prospective trials to try to define the optimal sequencing of therapies. And of course, what is the impact of prior therapies in the localized setting, for example, in the context of Niagara trials and others.
So great time to be in bladder cancer, and clearly an evolving field. And we thank everyone for your time today.